first speaker is Dr. Devashish Das, and the topic is snowball. So let us see what he wants to convey in his deliberation.
Thank you so much, sir. Thank you for the kind introduction. Basically, snowballs is basically we'd like to convey the intermediate uveitis part in our day-to-day practice. So snowballs. Basically, snowballs exudates are exudative materials which break loose from the aggregates and float in the vitreous cavity. And they float as vitreous snowball opacities. Apart from that, we also have snow banking, where focal globular yellowish exudates, we can see the coalescing to form the massive plaques over the pars plana. These may circumscribe the whole of the pars plana or the peripheral retina, particularly the inferior portions. You can see these vitreous cells are there, as well as the vitreous strands, as we can see, forming ultimately snow banking, particularly in the inferior periphery, leading to pars planitis or intermediate uveitis, which is associated with the snow banking. Usually these situations are idiopathic. Usually the site of inflammation is the ciliary body, as well as the vitreous, as well as the peripheral retina. If we go back into the history, it has been named differently over the years by different authors. Cyclitis by Fuchs, Skiffens called it as peripheral uveitis, Welch told it as pars planitis. Ultimately, IUSG group termed it as intermediate uveitis. However, the first detailed documentation of pars planitis was done by Charles Skiffens way back. And ultimately what we see as intermediate uveitis is inflammation that predominantly involves the anterior vitreous, the peripheral retina, as in the pars plana of the ciliary body. The pars planitis is a type of intermediate uveitis in which the snowball exudates in the vitreous and the snow banking formation in the peripheral retina. Sometimes there is no association with any of these systemic diseases. If we go into the epidemiology, we have 8 to 22% of all uveitis cases and 16 to 33% of all pediatric uveitic cases, and 80% of these cases are bilateral. Usually the age of presentations of these forms of intermediate uveitis is the third decade of life, and the average age of presentation has been from 23 to 28 years of age group. If we go into the incidence part of it, it is usually 2 per 1 lakh of population as per the previous studies. What is the pathogenesis? The exact cause is yet to be known. However, it is thought to be a cell-mediated immunity with a preponderance of the T helper cells and increased sensitivity to the retinal S antigens. It has been identification, quantification and purification of a 36 kilodalton protein circulating associated with the active pars planitis, as noted in one of the research studies. What are the symptoms the patient presents with? Usually the patient presents with floaters, painless blurring of the vision. Occasionally there is a dramatic visual loss when there is a vitreous hemorrhage or a CME or a disc edema. If there is a pain, it is usually associated with secondary glaucoma. What are the signs we look for? In most of the situations, it's a quiet eye. In the later stages of the disease, the patient can develop a band-shaped keratopathy. Most of the situations, there is a mild anterior chamber reaction, and in case of when the etiology is of sarcoid or a TB, we can find mutton fat keratic precipitates in the endothelium. There can develop peripheral anterior synechia and occasionally a posterior synechia when the etiology is a sarcoid or a TB. Secondary glaucoma is one of the consequences of this disease. In the posterior segment, we get the vitreous cells and vitreous strands. We get the snowball opacities as well as snow banking in the later stages of the disease. Sometimes we get a retinal vasculitis, and occasionally in the late stages of the disease, peripheral retinal neovascularization. We can see CME as one of its sequelae. There can be a retinal vasculitis. In the late stage, there can be tractional retinal detachments and a disc edema. These are rare but ERM sometimes seen in pars planitis. In children, in the intermediate uveitis is severe and the prognosis is poor. Sometimes these children present with band-shaped keratopathy. Pars planitis, however, is a self-limiting entity. The inflammation regresses on healing. The aggregates cicatrize to form a limited membrane which is grey or translucent in color and usually remains undisturbed in the eyes. There may be associated slight atrophy of the pars plana and the choroid in the later stages of the disease. Neovascularization happens when there is the ischemia of the peripheral retina leading to neovascularization at the retina, anterior hyaloid phase and pars plana. It is one of the dreaded complications of intermediate uveitis. If I follow the natural course, 10% of these patients they are self-limiting, 59% smoldering, and 31% keeps recurring during the course of the disease. The usual systemic disease associated with intermediate uveitis are sarcoidosis, tuberculosis, and multiple sclerosis. The differential diagnosis in these situations are Masquerade syndrome, particularly intraocular lymphoma, toxocariasis, Eales disease, and amyloidosis. What workup do we expect in a case of intermediate uveitis? You usually do the complete blood count, particularly the DLC and the ESR. We look for the chest X-ray and HZ-CT chest to rule out tuberculosis and sarcoidosis, MUN2, serum ACE and lysozyme even for sarcoidosis, and quantiferon TB gold test. The ancillary tests we do are angiography, UBM, and OCT. Usually it shows a petalloid appearance on angiography, particularly when there is a macular edema. UBM in pars planitis we do when the pupil is small due to the posterior synegia, you are not able to see properly, and when the media is hazy due to cataract. Particularly, we need to check this out when the IOP is low. OCT again shows the macular edema. It shows cystoid spaces in the macula and increased macular thickness in the pars planitis situations. Coming over to the treatment, the guidelines are basically you treat the intraocular inflammation, the CME, the cataract, the vitreous opacity is RD if there is any, and the vitreous hemorrhage. Most of the cases are mild, however, and responds only to the periocular steroids. If you go by the Kaplan's 4-step approach, we start with posterior subterenous injections. If the patient is not responding, we move over to oral steroids. If still it's further detrimental, then we give immunosuppressive agents, and ultimately for complications we go for indirect laser and vitrectomy. A few words about the posterior subterenons. Usually you use triamcinolone acetonide, posterior subterenons, and we can repeat this every month. Usually 2 to 3 injections will be sufficient for any such cases. For the oral steroids, only it is indicated in severe bilateral cases and where the failed periocular injections doesn't give me any result. Usual dosage is 1 milligram per kg of body weight, tapering 10 milligrams every week. You can use a low dose steroid if there is a protracted course and it needs to be continued over a prolonged period. When do we use immunosuppressive agents? It is during refractory cases which are not responding to steroids, and we use azathioprine 50 milligram 3 times a day or cyclosporin 5 milligrams per kg. However, mycophenolate mofetil is a very safe drug and can be given 500 milligram in a divided dosage. There had been studies which shows the efficacy and safety of mycophenolate mofetil in the treatment of recalcitrant intermediate uveitis, proving the same. When do we do cryotherapy? When the intermediate uveitis is not responding to the oral steroids, the neovascularization has happened in the vitreous base, and we usually use a double freeze and thaw technique in these situations. The latest armamentarium is the Ozurdex implant. The implant is placed in the vitreous cavity of the eye with a single use applicator in a sutureless office-based procedure. It can be done. And such studies are there in the IJO 2015 journal, Efficacy of Ozurdex Implant in the Treatment of Non-Infectious Intermediate Uveitis, which concludes that Ozurdex implant is a promising treatment option and efficient in controlling the inflammation and CME in cases of non-infectious intermediate uveitis not responding to the standard treatment. This is one of the implants in the vitreous cavity. And when do you do a vitreoretinal surgery? When it's an intractable vitreous inflammation, vitreous opacities and membrane obscuring the vision, unresolving vitreous hemorrhage, retinal detachment, and persistent CME in spite of treatment. There have been studies, pars plana vitrectomy versus immunomodulatory therapy for intermediate uveitis, which confirms that 82% showed resolution of the inflammation. However, 57% had persistent inflammation when even with immunomodulators you can go in for a vitrectomy. When do we go for a cataract operation in these cases? We wait for the burnt out stage to come, not in the active stages of the disease, usually 3 to 6 months when the eye is quiet. Preoperatively, topical systemic and pediocular steroids to be given to avoid further inflammation post-operative phase. Foldable IOLs are recommended and may need to combine with pars plana vitrectomy if there are vitreous membranes and opacities. The evaluation of cataract surgery in intermediate uveitis has been done by Rajesh Fogla et al., which shows vision improved in 94% of the eyes and 71% had visual acuity better than or equal to 618. To conclude, intermediate uveitis is a very puzzling disease. It is not an uncommon condition, and it is a challenge to us, the ophthalmologists. A meticulous examination of the pars plana and early diagnosis and proper management is the aim of this study. Thank you.
Thank you, Dr. Devashish. How long you put the patient on steroids post-operatively?
Post-operatively means after vitrectomy or after cataract surgery. See, if the eye is quiet, the normal steroid course we follow for the cataract surgery, that much is given. And if the eye is not quiet, we again revert back to whatever dosage we are given for the intermediate uveitis. It can be oral steroids if there is an inflammation. If there is no inflammation, we do not give steroids. It's actually we follow the protocol. If there is an inflammation, again post-surgery, we have to treat it again as an intermediate uveitis de novo, start all afresh.
Almost similar protocol for the patients whom you give subtenance, like
Usually we give pre-operatively steroids subtenance before 3 days before the cataract surgery, such that there is no recurrence of inflammation post-surgery. That is the crux of the story.
Thank you,
sir. Yes, sir. In smoldering cases, usually we keep a very low dose of steroids, and that keeps the patient's eyes very quiet. And sometimes methotrexate and group of drugs helps in these cases, because we can keep the steroid level low if we give an antimetabolite like methotrexate on a lower dose. It can be given over a period of 6 months, 9 months, even a year. It doesn't cause any side effect. 7.5 milligram per week every Sunday, and throughout week we give the folic acid.
Okay. Thank you, Dr. Devashish. The next speaker, I think Dr. Purendra Bhasin is not here. So I will invite Dr. Alok Ketriwal. He will be speaking on treatment opportunities in UK, training opportunities. meantime, may I know whether Dr. Ravi Mukesh Sharma is here? So next will be Dr. Ravi.
Just to confirm, there is no trainees here, or anyone who has trained in the last 5 years? So I will start with about
Dr. Veer Singh, he is also not here. I mean, it's a small hall, so I'm sure you can all hear me even without mic. So I will start my talk. I mean, this is just to give a flavor of how my career has progressed. So essentially what it says is that I have had training both in this country, in India, where I started, and I progressed to England, and I did my training in England as well. So I know the training system in both the countries. Just to recap, in ophthalmic training in this country is after your internship, you do about 2 or 3 years of postgraduation like your MS, and then some of the people will do if you contrast that to the UK training, so after the initial internship and the foundation program, there's 7 years of and then after 7 years, still most people will do about 1 or 2 years of training. So there's a big difference in how extensive the training program is. So, the topic of the talk is the opportunities at the moment. Now, I believe the training opportunities in England at the moment is very good. And the reason is this, that in 2006, they stopped the permit-free training, and that sort of reduced the flow of doctors from England, from India to England. And in 2016, as you know, the Brexit happened, and that stopped the flow from Europe to England. So what has happened now is that there is shortage of doctors in England. So that gives the opportunity that people, if they want to go from India to England, the job opportunities at the moment is very good. So it's probably one of the best I've known in the last 30 years. Job opportunities there. There's a good working environment, good training, and there is a decent pay. So all the right factors are there. So if someone is willing to put the effort in, this is the right time to look into getting some training in England. So how do you get into England? How do you get into the system? So you can probably inform all your juniors who are interested. There are 3 requirements to work as a doctor in England. You need to have a GMC registration, you need to have a job offer, and then you need to have a visa. So if you have the GMC registration and if you have a job offer, then getting a visa is not a problem. So the first 2 is important. If you can overcome these 2 hurdles, then you can get a job in England. So let's look at the GMC registration first. So
cannot work in England unless you have a GMC registration. And there are only 3 ways of getting a GMC registration. You can do a PLAB and get it, or you can do a first year's exam from any of the English colleges, and then you can be registered. But if you don't want to do a PLAB, you've not done the first years, then the third way, which is called MTI, or double sponsorship, or medical training initiative. So people generally, all of you probably know about PLAB, and most of people know about the fellowship. But people generally don't know about the MTI, so let me just tell you about this. So the MTI works whether it is called dual sponsorship. So there's a 2 sponsor. One is an Indian sponsor. So ophthalmologist trainees guide normally would be the Indian sponsor, and the UK sponsor. So let's say I can be the UK sponsor. I'm a UK consultant. So the UK sponsor finds a training job for a particular trainee, and the Indian sponsor contacts the UK sponsor. The 2 agree that this is the right candidate. The candidate goes through an interview process, and then he can be placed into that one particular training program. And the training program can be up to maximum 2 years. So you can work in the 2 years as a trainee in England without doing the PLAB, without doing the fellowship. So that's a good opportunity if someone doesn't want to do the PLAB, doesn't have their first years. Now, MTI has been around for since about 2008, but because there are lots of rules and regulations, it's not very popular. So there is a visa cap of about 1,500 per year, but only about 850 places were filled. So there is scope there. So if someone goes through the paperwork, then they can get into this medical training initiative. So there are lots of rules and regulations. They're all doable, but you have to do the trainee has to do paperwork. Essentially, these are the gist of it. You have to be in training for the last 3 or 5 years, including the last 1 year you have to be in the training. You need to have a postgraduate qualification, so either DO or MS or DNB. And you cannot enter into the program if you failed the PLAB test. So you have to choose at the very start whether you want to go through the PLAB route or the double sponsorship route. So if you fulfill all these guidelines, then most of the training can get into the system. Briefly, I'll tell you about how the health system works in the UK, because the first hurdle is getting the GMC registration, second hurdle is getting a job. So as I mentioned, you can get a job through double sponsorship, where the UK sponsor will arrange for the double sponsorship. So the health system works. Most of the health system is given by the NHS hospitals. NHS hospital is government hospital, but I would say 99% of the health system is given by the NHS in England, and it is all free to the patient. And the NHS system is probably one of the best healthcare system in the world. So we have all the gadgets, all the modern gadgets, and we are free to choose whatever we think is the best for the patient. So we don't have to ask. When the patient doesn't pay, all the payment comes from government, but still we have one of the best systems. We have all the modern gadgets. We can do what we think is best for the patient. So that's, and almost all the UK consultants you see, we are all based in NHS. We do a little bit private patient, but most of our work is in the NHS. Now, in the NHS, there are 3 regulatory bodies which supervises our work. So it's the GMC, which registers all the doctors, then the Royal Colleges. So all the specialty will have Royal Colleges. So for us, Royal College of Ophthalmologists, they supervise our work. So that's the second body. And then each area in the hospital, there is a deanery. So in my area, I work in Lincolnshire, and so it's a Trent deanery, which is Leicester and Nottingham. So all the trainees, SPRs, in ophthalmology, in all other branches, they are all overseen by the deanery. So there are three regulatory bodies which supervises our work, and then we work in the NHS hospital. And within the hospital, it's actually very friendly and very logical way of working. So we have these doctors in any specialty. So let's say in my unit, top of the pyramid is the consultants. There are about 7 consultants, 13 consultants in our unit. And there is the middle grade doctors, associate specialists, staff grades, specialty doctors. So these two, the first two are the permanent doctors. Then you have the trainees, which is SPR, and then you have the fellows, which can be a junior fellow or senior fellow. So that constitutes the whole department. Now the consultant is in charge of the running of the department. We make most of the decisions, and most of the interviews and the appointment is done by the consultants. So that's the structure. It's a very friendly environment. It's like an extended family. We know each other well. We help out each other. And the juniors, when they have any problem, they come to us, and it works very well. Training system in the UK, as I said, it is 7 years of run-through training. So after internship, but during the internship, the local candidates will apply for the training post. If they're selected, then they have 7 years of run-through training, so they don't have to apply again. So after 7 years of structured training, then they are entered into the specialist register. And you can only become a consultant if you are entered into the specialist register. So after 7 years, they get into the specialist register. Then most of them will do 1 or 2 years of fellowship, and then after 8, 9 years of training, then become a consultant. So you can see that the training an average consultant gets is much higher than at least in India, where you can become, let's say, a consultant in 4 or 5 years, where there were 8, 9 years of training. So much more extensive training. So I think there is some scope for the Indian trainees to get some more experience onwards. So it could be England, could be anywhere else, Canada, Australia, even America. But the level of training is much different in the two countries. Now, how do you, so when I started, there were 3 requirements to work in the hospital there. So one is getting a GMC registration, second was getting a job. So we come to how do you get a job from here? So there, if you go through the double sponsorship, then your UK sponsor will arrange training for you. So the training is already arranged for you. But let's say if you go through the PLAB route, or if you do the fellowship and then get registered, then you have to look for a job. And you can apply on job here. So you can find the job here, which is free for everyone to look into. It's called NHS Jobs or BMJ Online. And if you like a job, you can apply online. And it's quite simple. Once you fill up a form on the application, then the same application can be used for other jobs. So it's only one-time work. And then if you are shortlisted, then the interview now can also be done online. So most of the job hunting can be done from here. So the important question now is for the training, or if we want someone who wants to go to England, which route to take. If someone is fresh for after MBBS or have done the 10 subject preparation, they are ready to take a PLAB. So I think PLAB would be the better route for get the PLAB done. And then after doing the PLAB, that's first, after the MBBS, that's probably the best route to take. If someone has done the whole training, they are comfortable with their skill and knowledge, then they can do the fellowship exam, and that way they get a GMC registration. These two routes, in my view, is the better route to take. Because the advantage is that if you get a registration through PLAB or FRCS, you can apply for any job, and you can stay for any length of time. Whereas if you go through the MTI double sponsorship route, you you can only work in that particular job, and the maximum you can work is for 2 years. So there are pros and cons. But if you want to do PLAB or a FRCS, then you have to do a PLAB or a FRCS. So if you don't want to do that, then the MTI route is the third option. But preferred option in my view is the PLAB or FRCS. So, well, this talk was meant for the trainees, but it's still, that goes for any interview. You know, you need to prepare well for the interview. So, I would summarize it by saying that I think every young ophthalmologist should get as much training, as good a training as possible. That will work for them for the whole year. There's lots of support. The college website, the GMC website, the government website have lots of information, and we are there. All the UK consultants are there to help out if as necessary. So they are all the pioneers during my career in the last 30, 40 years in ophthalmology, and there's no reason why young ophthalmologists cannot follow into their footsteps. And I wanted to leave them with this image of Rishi Sunak becoming the Prime Minister. You know, the sky is the limit for all of us in the UK. Thank you.
Thanks, Dr. Alok, for giving an overview of how you can proceed for training in the UK. Thank you very much. So the next speaker I will invite is Dr. We will be speaking on redemption of PMMA IOL in cataract surgery. I request all the chairpersons and speakers to please stay on for a group photograph at the end of the session. Dr. Mahipal, do you have a talk in this session? No, no? Next session. Naresh.
Good afternoon, everybody. So here, just I'm going to show some videos how in a government setup where the cancer is going on, and we are using the PMMA lenses, and that lens when get into the vitreous cavity, how we are rescuing it and again refixing it. So in SICS, use of PMMA IOL is very common. Placement of PMMA IOL with poor general support, as in hypermature cataract with weak zonules, pseudo-exfoliation, trauma, or Marfanoid features, or in case of large PCR that leads to dislocation or subluxation of IOL in the vitreous cavity. Eye drop most seen in the camp surgery and also common in the novice. That is our PGs and the new learners, they used to do these things. And once these IOL drop into the vitreous cavity, if talking certain situation, just like if the rim is okay and vitreous loss is little or something like that, we can rescue that IOL with support of vitrectomy and use of PFGM. So I'm just so these are the incidences where the PCR is usually occur. So I'm not. This is showing about phaco things, but I am talking about the SICs. So here how I am managing. I am working in a government medical college. I'm the veterinary consultant there. The video system is not good, but it has been taken to the mobile. So once we found the rim is okay, then so here you see, so the patient was operated by one of our resident doctor, and when he was putting the IOL, just go through the PCR. So here we are, because we have taken through the mobile, so the recording is not good. You just see how the IOL is sitting over the macula. So after doing the 3/4 vitrectomy, we put some PFCL, because PFCL here is required because we have to protect the macula. So if you want to catch hold that haptics or body, we can touch the macula and injure that thing. So we are just putting the PFCL because to cushioning effect, so that the IOL is sit over that PFCL, and with forceps we just remove it out, and then we will take it out through that original SICS wood, and with we used to because we want to free vitreous free the anterior chamber, because that left out vitreous may cause pupillary block. Also, that vitreous can be in the angle that will cause secondary open angle glaucoma, as well as sometimes we have the Irving gas syndrome. So, with triamcinolone assisted, we will identify the vitreous and remove it out. And here, once we found the PC rim is okay, posterior capsule rim, so we are just negotiating and putting the IOL there. So you again just identified with the CNC hook, we are placing it in the ciliary sulcus. This is another video, so I am going to the another video. So here, that is actually the same thing. So we are doing the classical 3/4 vitrectomy, 25 gauge. Again, that you see that IOL is sitting there. So we are removing the vitreous. So this is the PFCL we are using. So this is the triamcinolone assisted vitrectomy. So this is the similar procedure, and I am going to another one. So here, what is there actually? This is a 3-piece PMA. It is a very old one, and so that has been subluxated, dislocated in the vitreous cavity. We have rescued these things with that proline haptics. We just do it as the Yamane technique. So you put it and make the scleral flap and put it in the creates a scleral tunnel and put it there. This one. Because our recording system is not there, so we used to do like this.
These CAD patients you bring back to the medical college and then perform the VR interview.
This was operated in a very from camp. There, this patient has referred to us. So in that case,
No, that's what I'm asking. Do you have a VR backup in the camps also? No. And the patients are brought to the medical college and there you.
there.
Yeah, that's what.
placed there. With the mobile, we are recording. Yes, yes, sir. So this is the thing, sir. And this is again because so Jugaad technique, sir. So here, so this is the we are actually pulling it out the haptics. That is the rolling haptics of the three-piece owl, and we are just insulating through these things. So my take-home message here actually. So these things can happen any time. So we are the seniors, so we should always stand near our trainee or the students, so that this is if it is happening. Suppose sometimes the people what we are doing, so there is a little bit generalizes or big generalizes. They are not bothering for that. They are putting the IVL and it is going on. So if we are be with them and observing these things and telling that this is the journal is not adequate or the PCR is not enough, PCR is enough, you cannot place that IVL. So by this way we can prevent these things. So number two, while placing the IVL in case of PCR or poor journal, be judicious. And if it is suppose 180 days journalolysis is there, I am putting these things and it is inferior, it is going down. So we should stop there. If the PCR is a little bit, okay, we can manage these things. But with a bigger PCR, if we are putting these things, it is going. So that is the thing.
And inferior rim should be intact. That
Yes,
is
sir.
very important.
Yes, sir. And another thing, that we must not hesitate because all our friends. So we should not hesitate to take help from the other subspecialties or deteriorative specialists are available. So we should not hesitate. So this is my talk. Thank you so much.
That's why you people are called troubleshooters.
No, sir. So by this, I am ending my talk. Thank you so much.
Thank you, PK. Thank you. So, any questions from the audience or the chairpersons? So with this, we come to the end of this session, and I will request all the chairpersons and speakers to please come for a group photo.